everyone, welcome to The Zest, the official podcast of Orange Kiss Magazine. I'm Chelsea Ranieri, and today's guest is the physician director of the Maternal Mental Health Program at Hoag, where her expertise includes the diagnosis and treatment of perinatal mood and anxiety disorders, premenstrual dysphoric disorder, and perimenopausal depression. She's received numerous accolades, including the American Society of Clinical Psychopharmacology New Investigator Award and the Klibanski Visitor Scholars Award. She also has 10 first author scientific publications. Thank you so much for being here today, Dr. Mercedes Szpunar.
Thank you for having me.
Of course. I am so honored because I had the privilege of getting to listen to you at the Hoag Her Summit last year. And I found everything that you said so fascinating and definitely an under-discussed topic. So I'm so excited to share your expertise with our listeners. But before we jump into everything, I would love if you could just give kind of a brief overview of what it is that you focus on. And also, I know I should know these definitions being a woman, but I feel like I have just kind of a vague understanding of perinatal, premenstrual, and perimenopausal. If you can just also give those definitions as well.
Absolutely. I'm happy to give all definitions, and do not ever apologize. I see physicians who've gone through medical school who've never heard of my specialty called reproductive psychiatry. So back me up at any point in time if you need me to explain. I do tend to be scientific and use jargon, so just say pause, explain. So important. Perinatal means pregnancy and postpartum. Arguably, depending on who you talk to, about a year postpartum, but that is kind of a definition that I go by. There's something I'll mention right now called the fourth trimester, meaning during pregnancy, we have 3 trimesters, right? First trimester, second trimester, third trimester. The fourth trimester is a term that's been around for some time, but really is describing that first 3 months postpartum. When a lot of people need a lot of help and they don't necessarily know where to turn, because when you're pregnant, I don't know if you've ever been pregnant, there's a lot of visits during the course of pregnancy, seeing your OB, your obstetrician over and over, and then your postpartum, they see you once or twice and say, okay, see you in a year for your annual exam. And so a lot of women are like, wait a second, I have more questions. I don't know where to turn. And so thankfully, my clinic exists at Hoag, and I work with a lot of the OBs very closely. Let me explain premenstrual dysphoric disorder. So premenstrual dysphoric disorder is a collection of symptoms, just like any mental health disorder. It's a collection of symptoms, and it's either happening for a certain time frame or a specific period. So premenstrual dysphoric disorder is symptoms occurring typically during the late luteal phase of the menstrual cycle. I'll back up and explain the menstrual cycle. Is typically 4 weeks. If a woman has a 28-day cycle, first 2 weeks are follicular phase. So that's when estrogen is increasing and the follicle is developing. The estrogen peaks, luteinizing hormone peaks, the woman ovulates. And then the next 2 weeks is the luteal phase. At that time, progesterone starts to predominate. Progesterone increases and then decreases. And when progesterone is changing, that is the time when a lot of women have symptoms of premenstrual dysphoric disorder. And so what is notable is the symptoms are happening on a monthly cycle, and typically on a very classic 5 days before the period comes, or sometimes it's for the full 2 weeks before a period comes. And symptoms vary, but there can be a collection of low energy, sleep disruption, just feeling unlike yourself, canceling social plans. And so for some women, this is actually the disorder that they have, and they've been misdiagnosed with, I don't know, bipolar disorder or depression, a bread and butter depression. And actually PMDD, premenstrual dysphoric disorder, has its own set of treatments and again, should be diagnostically evaluated differently. So what did I miss? Or are there things you want
to? No, that's, yeah.
And so PMDD it is not PMS. So premenstrual symptoms are short-lived, 1 or 2 days, kind of resolve on their own. PMDD can be highly disruptive and distressing and really warrant treatment. It depends, of course, on the person and how severe the symptoms are experienced or how long they last. But for some, it's so there are kind of your usual treatments, and there's sometimes more extreme treatments depending upon how disruptive the symptoms are. But that's PMDD in a nutshell.
Yeah, that's fascinating. What was the last one? Perimenopausal depression.
So for some women, they've had depressive episodes throughout their lives. For some women, perimenopause is the first time they're ever experiencing a depressive episode. And so this is still something where we don't fully understand all of the details, but it could be related to changes in estrogen, progesterone. These are hormones that, again, I just explained during the monthly menstrual cycle are typically going up and down. During menopause, these hormones are going down and then will stay low for the rest of a woman's life. There's been some controversy out there whether gynecologists should be prescribing hormones or not. There was a study about 20 years ago saying hormones could cause bad side effects. They could be causing either blood clots or could be causing cardiovascular issues, heart attack, stroke. As we've gotten more information, the research has been more enlightening. It was more of how that study was designed and what was the timeline of hormones. If a woman went through menopause at 50 and then the hormones were given at 60 or 65, those are really the people who the hormones may have done more harm than good. Whereas if women were started on hormone therapy around the time of menopause, it can be highly beneficial and really curb a lot of the menopause symptoms. Depression itself could be related to those hormone changes, or it might be an independent factor. But we know there's many variables that are involved in a possible depressive episode. There could be endogenous the signals. There could be other factors, social factors. So perimenopausal depression is specifically depression occurring in the perimenopausal period.
So I recently saw something on TikTok, and it was saying perimenopause is now starting as early as someone's 30s. So is that premenopause or what's peri?
So perimenopause is the time approaching menopause. And so the time it starts for an individual woman is highly variable. Typical range is somewhere in the 45 to 55 range. But the key here is it's not a minute or it's not a day. Like, menopause, it's a phase of time when hormones are changing and a woman no longer has her menstrual cycle. For occasionally, it will just be end of menstrual cycles, but that's really the rarity. Usually there's more kind of abnormal cycles. And what that means is there's hormone fluctuations that are changing. Ding, hormone changes also happen during pregnancy, all of these things that I'm describing are related to hormonal changes. And that's the study that we know for the commonality of these disorders, PMDD, perinatal depression, and then perimenopausal depression. We know some factors are related to the hormonal changes, right?
Yeah. So this is all super interesting to me because I've talked about it before on this podcast, but I'm very much on the fence of I want to have kids or not. And I actually have an anxiety disorder and OCD. So a double whammy. But I've been in therapy for like maybe 8 years. And I feel like I've finally gotten to a place where I'm great with my mental health. I'm doing so well. And one of the reasons I'm on the fence is like, dang, I just got that fixed. And then if I not fixed, but to a better place. And if I get pregnant, will that then disrupt it? So I'm excited to dive in and we can go more into that later. But I would love to start with what initially drew you to science and medicine.
Okay, so this is, a bit of a broad and loaded question. So I would say in my family of origin, in my household growing up, it was very much education, education, education. You're going to school. You're going to, and this was both framed as a good thing for you, to benefit yourself, but also to benefit others, And so by pursuing a scientific career, I saw it as both something where I enjoy school, I enjoy learning. So it was something beneficial for me, but I also wanted to give back to the community, right? And so college was seen more of as like a jumping stone rather than the end. And I took that to the nth degree with 9 years of graduate school and or postgraduate education with residency and postdoc fellowship. But so the first, I'd say, real exposure I had to medicine was at a science symposium for adolescents. I was, somewhere around 11 or 12, and I was learning all about, different laboratory techniques or what life would look like as a scientist. And then there was a career fair. At the career fair, I met an OBGYN, and she was showing an ultrasound of babies and also a few different gynecologic procedures that she had performed, sometimes with patient permission. They film procedures. And so I saw this video and I was like, wow, that is such a cool thing you can do. You can train to treat treat people and help them feel better, remove a mass if it's causing them harm or pain, or watch a baby grow throughout pregnancy. And so that really struck me as a cool job, let's say, that is something that I felt strongly about. I was like, what's better than helping moms have healthy babies, So that's what really drew me, I'd say, to the field of reproduction and medicine in the first place, in addition to, again, being interested in science and just, I guess, having a creative mind. I think science is an ability to be creative, really. Like when you're doing experiments, you're following protocols, and it's a way to think of how do we advance science, or how do we change science, or what else can we do? And so this seemed like the right fit for me.
That's so interesting. I interviewed a surgeon from Hoag, and she also said the same thing, that it's really creative. And I never would have thought of it like that.
Yeah. Yeah. And so an analogy here, kind of, like an artist, right? That you're using your skills and using the things that you know and like, but it's how do you adapt and how do you make it worthwhile, in my opinion, for both yourself and for others. I don't know if, I think you're talking about Dr. Raskin, who I know and love. So I will mention the term doctor means to teach, right? And so what's more rewarding, again, than helping others learn more about themselves and more about how to stay healthy and well. And so that's really what drew me to medicine and why I love the work that I do.
Oh, wow. Well, you trained at UC San Diego in both psychiatry and women's mental health. So what did you learn during that time that really sparked your passion for helping specifically pregnant and postpartum women? Or did you go into that before that?
So I'm going to take you back a few steps. So when I was in grad school, I studied stress and breast cancer. And so I found a mentor at my graduate school. I went to University of Rochester School of Medicine and Dentistry, and I was looking for a mentor and a thesis project. And I thought, again, how cool is this, that we can study a physiologic process, stress, and look at cancer, and specifically breast cancer, which is a highly prevalent disorder and something that we need more science on. We need more data. We need more things in our arsenal to treat this illness. And so I studied stress and breast cancer. And at the time, I thought, grad school, I'm going to use this somehow related to pregnancy. Either related to pregnancy itself, like why is stress negatively impacting pregnancy, or also I considered thinking about stress and conception. Why do women have infertility and they struggle so much to get pregnant? They finally do it with the help of the reproductive endocrinologist, and then they have their baby. A year later, they have a pregnancy spontaneously. What is going on, hormonally speaking, stress speaking, that is letting the physiology change so that someone who struggles to get pregnant for years can get pregnant spontaneously after they've already had a pregnancy? So again, those are kind of like phases of time that I both thought about a lot during graduate school. And then during my third year of medical school is when you do the different rotations. And I'd always thought I was going to be an obstetrician gynecologist, OBGYN. And everyone had always said, Mercedes, you're not going to do that. And I'm like, why not? And really, you have to be a surgeon. They are surgeons, and you have surgeon mentalities, and you got to act. If someone's life is in danger, you got to make a decision. In my scientific mind, I like to think. I like to take a step back. I want a little time to decide: is this the right decision? Is that the right decision? And that became very clear to me that was not going to work well with the surgeon mentality and needs of an obstetrician. If baby's got to come out, got to get the baby out, right? And so when I did my psychiatry rotation, I learned about reproductive psychiatry for the first time. It was like directly following my OBGYN rotation. And so I learned about this specialty, which has only been around for, 10 to 20 years. And again, a lot of people, even physicians, have not heard of those terms, perinatal and reproductive psychiatrist. And what it is it's a psychiatrist who's done some extra training or focus on these phases related to the hormones, just like I told you, the PMDD or the menstrual cycle changes, the perinatal changes, or the postpartum changes that can take place, or perimenopausal. And so once I learned that specialty, I'm like, this is the fit, right? This means I get to talk to my patients as long as I want and think about the treatment options with them. I get to treat pregnancy. I get to treat postpartum. I also get to treat, preconception if moms are having questions about that. And so really it just hit home to me that this is the right field and specialty for me.
God. And something like like if I ever do get pregnant, I'm coming to you. I feel so like safe with you.
And that is one of the key things, again, throughout the course of the multitude of training that I've done. One of the key things is you have to make someone comfortable. If they're not comfortable, they're not going to come back or they're not going to believe you. And so what I do as a reproductive psychiatrist is we call it shared decision making. If you were my patient, Chelsea, I'm meeting with you. I'm assessing how you're doing. You're telling me what's good, what's bad, what am I concerned about? And then I'm going to give you an array, a menu of options of what to consider. Do we continue therapy? Do we consider medicine? Or do you take medicine that you've already been taking because it's been so helpful for you? These are the kind of decisions where I partner with you. Ultimately, you get to make the decision with the science I've given you. And I'll tell you if I think it's a bad idea, but that's the key. It's shared decision making based on the sound data that we have so far. That's always to say, science and medicine, we're always learning new things. That's the fun thing about being a doctor, lifelong learning. There's always new things to discover and to know, right?
Yeah. I love that idea of like working. I feel like a lot of times if you go to doctors, just like, this is what you're doing, here it is, rather than being like, for example, I'm on a migraine preventative because I'm just getting them so frequently. And I was given a migraine preventative. It totally works. I had no idea that it's also an antidepressant. And I was like, wait, what? No one told me that. He was like, it'll boost your mood. It'll get rid of your migraines. You'll have better sleep. And I was like, great, give it to me. And it is a lower dose than what they would put someone on for an antidepressant. But there was no real information that was given to me. And not that I'm upset about it because it works. But I was like, I would just wish I would have known that going into it. So I like the idea of getting to have that information and make a decision. And I just want to fast forward a bit because I want to make sure we get into the weeds in the short period of time we have. But so back in 2018, Hoag launched the Maternal Mental Health Clinic. What were some of the biggest gaps in care that you saw at the time? And how have you helped the clinic grown since then?
So, full disclosure, I was not director of the clinic at that time. Dr. Patty DeMarco was the initiator and first reproductive psychiatrist in the clinic. At that time, there was 2 therapists, 1 reproductive psychiatrist, and the clinic has just expanded and grown and grown. We now have 10 clinicians and therapists, and we're looking to hire because there's just a demand. There's such a high demand. Hoag and the facilities, there's 2 hospitals where we deliver. There's also a lot of outpatient sites. San Juan Capistrano is opening very soon or has already opened, one or the other. And so Hoag is just ever expanding, and that means more referrals to me if more moms babies. I think we have 8,500 babies in 2024, and we're set to hit 10,000 very soon. So that means more moms having babies. And of course, my OB referrals, the OBs that refer to me and the OBs that I work very closely with, they know there's a need for care. And so the clinic has just ever grown. I would say in terms of the needs, so the needs of a mom are always individualized in this clinic. Some moms call us and they say, I want psychotherapy and it's the only thing I want. And so we get them into psychotherapy, but I also work very closely with the therapist. And sometimes the therapists say, hey, Dr. Szpunar, I'm really worried about this patient. Can you evaluate? And the answer is always yes, if they want to meet with me. I'm never going to force someone to meet with me, but something that can be crucial for certain individuals is that therapy and medicines can work together. For some, therapy is great in and of itself. For some, medicines are great. And they say, I don't have time for therapy. Who has the time and the money? Because we do take insurance in our clinic, but therapy can be, for other providers in the community, mental health carve-outs, unfortunately, it can be very expensive. So again, this is where this is shared decision-making. If a patient comes to me and says, I want medicine, not therapy, I'm going to meet them where they're at. I also tell every patient I meet, you should consider psychotherapy because it could be beneficial, right? So,
What are some of the, I guess, most common issues that you're seeing women come in with? And then what are also the solutions that go with that? Because I would assume that, just seeing my friends who have been pregnant, that some people might be hesitant to take medicine while they're pregnant.
Yep.
So I guess,
So common issues being common, depression throughout the perinatal phase is somewhere between 10 and 20%, what number you look at. Anxiety in the perinatal phase is up to about 20%. So if you combine those, depression and anxiety, you pregnant through a year postpartum, we're talking 1 in 4 women will experience both of those things. So the numbers are very high, as you can tell by that. I can tell by your expression, like, wow.
Yeah, that'd be me.
I'll be honest, medicine isn't for everyone, especially when they're pregnant. And that's if I'm meeting, again, a mom who says, I want to do the best by this fetus. I want to take care of him or her, but I'm also very nervous. They've never taken medicine before. That's where I say, I want you to do therapy today, now. You and I are going to keep meeting. That's not the primary treatment that I provide, but postpartum, we're going to continue meeting and we're going to continue to evolve this conversation, because I have a lot of medicines that I would say reproductive safety data, very low transmission in breast milk. I have a set of medicines I can prescribe. I will say another disorder that has been coming more to light is attention deficit hyperactivity disorder, ADHD. With this, your classic is you think of the 7-year-old boy jumping out of his chair at school. And so the teacher's the parent saying this, your child needs something, right? He needs evaluation. He may need something to help him to focus in class. ADHD in young girls and women doesn't always present with the hyperactivity. It's often more of the inattentive or the difficulty with scheduling, difficulty with completion of tasks. They're losing the wallet and the phones, and they can't get into their door or their work because they left the keys and they don't remember where they are. And so ADHD, again, is like any psychiatric disorder, is a cluster of symptoms. How long have the symptoms been present is one of the diagnostic criteria. Also for ADHD is it in two places, meaning is it at home and in the workplace or the school? And so if it's only in one of those places, it might be something else. But if it's diagnostically meeting criteria, I meet women all the time. A 35-year-old woman this year, I can think of, who's been struggling with ADHD since childhood. I gave her an ADHD scale. I said, give this to me. Tell me what you're struggling with. And she looks at me and goes, why didn't someone give that to me years ago? Struggling so much for so long. Why didn't someone offer this to me? And I said, I'm sorry, I'm meeting you now, but I'm going to help you. I'm going to help you. Time. So that is definitely a disorder that has been getting more attention in social media, in warrants treatment, warrant some kind of treatment. I will say whenever I'm meeting with a patient, I just discuss, as I'm saying, menu of options. So of course I prescribe medicine. That's what my training was in psychiatry and reproductive psychiatry. But I'm always talking to them about psychotherapy and potentially different therapy options. And I also talk about behavioral interventions. I tell them there are things you can do to help yourself feel better. And that includes nutrition, diet. Sometimes I have to use that word carefully, nutrition. Exercise or movement, and then also sleep, getting good sleep hygiene and getting good sleep quality. Guess what? If we're not sleeping well, we don't feel well. We feel irritable. We feel snappy. And so I'm always speaking about those behavioral things. Also, we know connecting with nature can be good for, again, anyone, or also any psychiatric disorder, being outside, seeing green space. All those things can be highly, highly beneficial. And so if I'm meeting with someone, they're like, I really don't want medicine today, then I say, look at these other options. Let's engage in those as much as possible. And then let's keep meeting and figure out how do we get you feeling your best.
Yeah, it's interesting. So I saw, again, TikTok, I'm chronically on TikTok, but I saw a TikTok where this woman was saying she had just had her baby and she felt like when she was holding her baby, like she didn't feel that joy they're supposed to feel. She didn't feel connected. She got home and she's like, I love my dog more than like, this feels crazy to me. And she posted about it. And a lot of women were saying they felt the same way and they didn't know it's called the baby blues, which seems like a really cutesy way to say postpartum depression. But what are some, I guess, symptoms or signs that you have depression? As you mentioned, some women may have not experienced this before. And then when they hit perimenopause, like what are some of those, I guess, subtle signs or just signs in general?
So first, let me define postpartum blues. What is it? What do we describe it as? Baby blues is very, very common. 70 to 80% of women have some amount of baby blues. We attribute it to the hormones that have done they trucked up like a roller coaster, like chick, 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 chick. Estrogen increases tenfold. Back up. Estrogen increases 50-fold during the course of pregnancy. Progesterone increases tenfold. So both those hormones go up high throughout the course of pregnancy and then drop off the cliff right after the baby comes out. And so baby blues is attributed to those hormonal changes. I describe it to moms is, I'm warning you, this could happen. 1 minute you're happy, 1 minute you're sad or crying and you don't know why. 1 minute you're holding your baby smiling, the next minute you're yelling at your husband. That is normal with baby blues early postpartum period. Should last days to weeks. It should be about working its way out by 1 to 2 weeks postpartum. That is why every patient that I take care of during pregnancy, my goal is to check in with them by 7 to 14 days postpartum, because I want to assess, are you having baby blues? And if you're having it, is it getting better or is it getting worse? That is the key. Baby blues is brief, resolves on its own without treatment, whereas postpartum depression does not resolve, at least in a short time frame. Postpartum depression can resolve without treatment, but it also might last for a long time. It could last years if a woman doesn't get treatment of some kind.
Wow.
Yeah. I actually met a mom this morning and she was describing her first pregnancy postpartum. She didn't feel well until her baby was 5, and now she's just her second baby. And I'm like, I'm so happy. I wish I met you sooner, but I'm so happy I'm meeting you today, because we're not going to have that same path. We're going to redirect this train, let's say, and get you on the right path with treatment, because postpartum depression can last a long time without treatment.
Mm-hmm. What a relief she must have felt. Oh my God.
That's exactly, to saying that. By the end of the visit, I asked her, I'm meeting people who describing depression, mood changes, up and down, sadness, tearfulness daily, irritability, not having good sleep. They're not able to fall asleep. Their thoughts are going, intrusive thoughts that are scary, or just thoughts that they can't stop. These are very common symptoms. If it's been 2 or more weeks, either it could start during pregnancy or postpartum. That's the definition of depression, that they're having those symptoms for 2 or more weeks. A few other associated symptoms. They might be feeling hopeless. They might be having thoughts of suicide. It can be really hard for people to be sharing and disclosing this information. I'm often the first person they're telling this to. And of course, so creating that safe place is really important. And by the end of the visit, I'm saying, how are you feeling right now? And she's like, I'm actually really relieved to be talking to you about this, because producing tears as she's saying that, because it's so hard to be saying some of the things she's admitting out for the first time, but she's relieved that she knows she's going to get closer to getting better. Right.
Yeah. Oh my gosh. So some women don't feel comfortable even going to their husbands about this. You're the first person that wow.
It's highly variable. And that's why
partners.
A partner, or I also ask people, who's in your social support? It's often husbands, and that can be a mixed bag, right? Sometimes dads are dealing with postpartum depression. Postpartum depression with dads is about 1 in 10. So that's also a common thing that isn't either well known or it's not always discussed as much. And if a woman you're saying on TikTok, you're looking at moms or prenatal experiences, some moms aren't really leaving the house much, or they're feeling socially isolated because they don't feel comfortable taking the baby out. They're worried about sickness. They're worrying about something bad happening to the baby, all of these things. And so they're feeling very isolated in their home. And that's a sign of depression of itself. So it can be chicken or the egg, are these behavioral things? You're not leaving your house, so you're depressed, or are you depressed so you're not leaving your house? And that's part of, my investigative work, that I have to figure out, where can I move this mark, and how much benefit can we get? I absolutely have moms who I've met with, and I counsel on nutrition, I counsel on sleep, I counsel on exercise, and I see them a month or 2 later and they're like, I did what you said, I'm feeling better. Another big one I always talk about is, again, the movement piece, walking in the morning. The sun is giving your brain a signal it's time to be awake, and this can help regulate sleep-wake cycle, right? Whereas if you're a postpartum mom, you're awake all night, you stay inside all day, your body doesn't know when it's morning and when it's nighttime. It gets very confused. Another really important thing is vitamin D, in my opinion. We make vitamin D from the sun's rays on our skin. We live in Southern California. You think everyone would have plenty of vitamin D? Not the case. A lot of the labs, whenever I'm meeting a mom, I say I want to offer a few different labs. One of them is vitamin D. It's often low 30, which is the mark of normal range. I often see 20s or teens. And so what is the answer here? I want to replace it somehow, either go outside and get some sun exposure, not too much, not too much. We don't want any too much overshooting the mark too much. I don't want skin cancer. I don't. Vitamin D production or a supplement, and oral supplements can do a lot to increase vitamin D levels as well.
How many minutes per day? Because I work from home, and there's some days I only take my dogs to go to the bathroom and then I come back inside. How many minutes a day should you be going outside?
I would say I can't give you an exact number to produce healthy vitamin D levels, but I would say walking somewhere between 20 and 30 minutes is usually good one for movement wise, good for at least getting some amount of exposure outside time on, again, the green space piece. And then you're making some amount of vitamin D, but I would have to go to your medical professional.
Yeah.
You need a vitamin if it's warranted to have a vitamin D level. The key thing I know about pregnancy postpartum, we think of vitamin D as really important for bone health for us. But remember, women who are pregnant are building baby bones. So vitamin D is helpful with calcium absorption for the individual, but women who are pregnant need to build a baby. And so it's important for that. It's also important for immune health. Vitamin D is one that we know can help boost immunity. I also think of it as important for reproductive health or mental health. It's involved in serotonin production. Serotonin is one of the monoamines that I want to target. If someone's they're feeling stressed, they're feeling anxious. If we increase serotonin, that can allow them to feel more settled or more relaxed.
Interesting.
Yeah.
Well, I'm definitely probably low on vitamin D. I need to get out of the house more. But okay, well, for someone, sorry, what'd you say?
Go to your medical professional and have a level drawn, and they can guide you.
Exactly. Well, for someone like me, who I mentioned does have anxiety, OCD, because I am, I don't know if prone's the word or just that I have it. What do you tell patients who already have that and then go into pregnancy? I'd be scared that it would get worse, or I'm not sure. Yeah.
This is what I tell them because this is my honest clinical experience. Mm-hmm. I cannot predict if I'm meeting someone for the first time, either they're taking medicine or not, or they're in therapy treating OCD, anxiety, depression. I cannot predict how they're going to do throughout the course of pregnancy. And that's when I tell them, I'm partnering with you. We're going to keep meeting is my plan, because I've had some women say, this is the best I've ever felt during pregnancy. I've honestly heard that from more than one woman, I promise you. And they say, this is the best I've ever felt. I've also seen the opposite of women saying, this is the worst I've ever felt. Because what are some challenges that come up? So first trimester is hard for a lot of women. Why? Again, you're building a baby. You're built from stage 1, right? And so that means you have higher sleep requirements, meaning you don't want to get out of bed. You have low energy. You're not eating the way you normally would. You might be nauseous. You might be changing, craving carbs. Carbs might spike your, glucose level, and then it dips. And so there's a lot of inherent changes in early pregnancy. Women stop exercising the way they normally do because they're having low energy and because they don't want to get out of bed. If I'm meeting a woman for the first time in our first trimester, it is really, really hard for me to discriminate what is early pregnancy symptoms versus is this real depression. It can be very challenging. There's, of course, some telltale things that I'd get worried about. If she's having, for example, suicidal thoughts, that's depression. That is not a pregnancy symptom, compared to if it's low energy and I'm having trouble getting out of bed because I'm so tired. That might just be early pregnancy. And this is where, again, that kind of nutrition and dietary counseling can be so crucial. Also, I want to tell them, you will hopefully, most women feel better by second trimester. Usually a lot of the nausea has gotten a little bit better, and it's the honeymoon phase where there's a little bit of energy. You're able to engage in your normal routine until you get to third trimester. You're like, I don't want to do anything. But maintaining what we can with our muscles, with our fitness is really crucial to maintaining a healthy pregnancy.
Wow, that's so interesting. Well, thank you so much for sharing this. Is there anything that you want to shout out, anything exciting coming up in your work or your research that you want to share with listeners? Or will you be at the Hoag Summit this year?
I heard it already sold out. And
oh my gosh.
I was not invited to be a panelist, and I was not fast enough to buy my own ticket. I don't know if I'm able to go, but the past 2 years, it's a beautiful event. And I've, you probably heard last year, I think menopause is coming up this year. I think Dr.
Yes.
Haber is going to be keynote speaker. It's a fantastic event. I paused. I'm not sure what to share beyond clinically. Very busy. Again, get lots of referrals. So something I should mention: the primary work that I do in maternal mental health is pregnancy, postpartum. We do offer pre-pregnancy consultation. So, for example, if there's someone who has no one in this room, but if someone has OCD and they're taking a medicine and they want to know what are my risks if I'm taking this during pregnancy, our clinic does offer pre-pregnancy consultations as a one-time evaluation and recommendations that I can give to a woman. And then if she gets pregnant, I say, call the clinic back as soon as you're pregnant, and then I can take over care. Because we do find that people get lots of information in the community that sometimes is great information and sometimes not great information. For example, I have a reproductive endocrinologist who I work with who sent me a patient, was like, can you please see this person as soon as possible? Just gotten her pregnant. And her psychiatrist in the community told her to stop her medicine that she'd been on for 5 years. And I was like, no, that's the last thing you want to do.
Oh, no.
Timing is everything, right? And so that is someone that luckily we got in the clinic very fast. And she had a totally healthy pregnancy, and baby's already a year old. And so those are, again, those, the way I get to teach patients, the way I get to share in the experience. And it can be hard to correct information if they've gotten other information, but that's the key. I sometimes say, if you see 3 experts in the room, you might get 3 different opinions, but ultimately you're the one who has to make the decisions that are right for you. And as long as you're getting trusted information, and again, have someone who's going to partner with you to make right decisions, that's what's important.
Amazing. I'm going to share this episode with all my friends because I have a lot of friends right now that are either talking about getting pregnant or trying to get pregnant. So this is great.
And no one size fits all. Everyone has, and I can't, again, predict for one person versus another how things are going to be. But again, want to keep meeting and make sure I'm doing my best by you. And that's how we do it.
Yeah, well, I so appreciate your time, and we are coming to the end of it. But before I let you go, we have 3 final questions for you that I call the thoughtful 3. So first, what moment in your career has stood out as the most pivotal or transformative? If there's probably many, but if there's one that stands out. A period of time that was highly transformative for me. Of course, throughout the course of my training, I was in upstate New York for medical school and San Diego for residency. Early faculty, I was in Boston at a Harvard-affiliated hospital, Massachusetts General Hospital, and I had a number of really important mentors of different specialties. I had an internal medicine physician who was practicing lifestyle medicine. And so that was an important influence for me. I had a reproductive endocrinologist that I was talking to PMDD about and kind of getting her perspective on that one. And obviously did research on both psychiatric disorders during pregnancy and postpartum and on the National Pregnancy Registry. So that was a really formative time. I learned a lot. Both academically in terms of the clinician that I am, and I think it's made me an infinitely better clinician. I also, had kind of my own different social struggles, and coming home to Southern California was the right for my family. And so that was a very formative time for me, though, I will say. Yeah, well, thank you for sharing that. Yeah. If listeners could walk away with one key takeaway from this conversation, what would you hope that it would be?
No, there's help. It may be hard to find when you're, especially for postpartum moms, you're taking care of a new baby, you're sleep deprived, you're feeling underwater. This is where reach out to your contacts, your community, reach out to your OB, reach out to your friends. There is help available if you connect with the right practitioner or provider at the right time. My goal is always to get women better fast, but sometimes it takes some time, and sometimes there's some trial and error to finding the right fit. But no, there will be better days. We can get you better.
I love that. And then lastly, what is one habit or routine that you feel has helped you become successful in your career?
I would like to think, and this is a work in progress, being a good listener, because being heard is being seen. And to the example that I told you of the mom this morning, she was sharing with me. Either maybe she had shared certain things with her husband, but some of the things she shared with me was the first time she had shared them with any other human being. And there's both some amount of either guilt or embarrassment with that. But I know 20, 40 minutes later into our conversation, that turned into relief, that this wasn't something she was keeping all inside into herself. And so I don't know if I'm the best listener, but our words matter and listening matters. And every individual has their own story.
Yeah, I love that. And I can already tell that you're an amazing listener. But well, thank you so much for doing this. I had such a great time getting to talk with you. I feel like so empowered now if I do decide to get pregnant. So I really appreciate your time.
Of course. Very nice meeting you, and reach out if I can help in any way.
I definitely will.